file, check gallbladder 1. There's gallbladder 1. So it's actually a set point here, T5, T4, T5, gallbladder area. So what I'm going to do then is I'm going to measure something before and after I do that set point technique. Do you have something, how was your 1 foot stand? Did you do it?
Yeah. It wasn't so many per second.
Okay, and how was your finger to finger? That's good. Let's do the 1 foot stand.
Okay.
So, yeah, motion so stand on 1 foot. And you just do it again, same thing. Okay, do the other foot. One more time on the left one. I was given at least twice, unless they do this a well the first time. Okay, sit here again. Gallbladder, what test is T5? It's a regular muscle test. Resist is that cool. So I'm going to just do set point technique. I'm going to tap here about 100 times. And 100 times at the rate I'm tapping, which is about 4 or 5 times a second, will take about 20 or 25 seconds.
If the patient can't reach, what do you?
Patient can't reach. Good question. And in this area of the spine they can't reach, I usually tap it or rub it myself. I just do something to stimulate it so the brain's getting the message, the proprioception. Even though it's better when they touch it, it'll work. I usually tap a little longer when I do that. That's got to be 20 or 25 seconds. Okay, keep your hand there. Hold your arm in again. We'll tap again to make sure that it's better. And it still shows a need for some more, so we'll tap some more. Now, granted, we haven't done all the other things to her, so I don't know what's going to happen, but usually it should have fixed by now. I suspect we skipped over something that would have made this correct faster, whether it be an injury somewhere or a right brain, left brain issue, but okay, hold here again, resist, now tap again, resist. It strengthens now. Okay, now switch hands and put your fingers right up here on top, and then let's test with the cytokine, the TNF-alpha, that cause that brain reflex to weaken. Again, and it actually still weakens. Okay. So we've got to go back to the drawing board, and we could test the nutrients and so on for it. We probably should do that touch right here again. Let's just see now if she's got something else that maybe she's more than one thing and shows up maybe one at a time. Turn your head this way and tilt your head back again. Pull your arm in hard. And there's still something on that left posterior canal. So keep your head straight. I'm going to rub down the spine again. Pull hard. Pull again. It's really just about in the same area. It negates the weakness. Pull hard. Well, could it be a hiding hernia? It could be a whole bunch of things that would be associated with, we haven't checked yet, but I'm trying to just, yeah, it could be a lot of things. But yeah, that's a good point. And it still shows T5, so I'm going to ask you to lie face down for me. So it may be that the set point was there because there's an underlying subluxation, or maybe a fixation. Maybe a fixation, and that's what you find a lot of times. So, I'm going to challenge, and I'm not going to necessarily check for the bilateral muscle weakness. I'm just going to challenge T5 on T6 and T5 on T4, and hold your arm in here. Actually, hold your arm in here so people can see it. Push in. Challenge T5 on the left, T6 on the right, T5 on the left, T4 on the right, T5 on the right, T6 on the left. There it is. T5 on the right, T6 on the left, and there's a fixation there. T5 on the right, T4 on the left is between T5 on the right and T6 on the left. Now, this would be a thoracic subluxation. You would think that in typical AK terms there would be a bilateral what?
Teres
major. Put your fist in the spine back. There may or may not be. The point is oftentimes there's not. Push against me hard, please. have that. Now, sometimes you could add weight bearing, as if you were upright, push. But these type of fixations sometimes have been there for a long time and they're sort of locked in. I started to talk about this a little earlier and kind of got off track on it a little bit. You can get a fixation which doesn't show the bilateral muscle weakness because the body's so used to having it be there. And it may actually require manipulation to stretch the ligaments and break the, mechanical fixation's been there for a long time, like the chiropractic subluxation syndrome kind of subluxation, or fixation. So, hold here again, resist. When I find one like this, I usually do first a respiratory correction, then I adjust it. So I'm going to ask you to take a breath in. Push your arm in here. When she breathes in, it negates the weakness. So I'm going to correct this on respiration, then I'm going to actually manipulate it. I thought in my mind, and you can palpate for motion palpation to see the differences. But I have the idea that sometimes this really requires not just a correction of the subluxation, but really actually stretching some of the ligaments that have been there for a long time. So, do this again here. The right spot. Pull hard. Yeah, that's it. Take a breath in and let it out. Breathe in and let it out. Breathe in and let it out. So I'm kind of pushing apart, P to A, but also kind of pushing laterally on both sides. Breathe in, let it out. Breathe in. And now I'm going to adjust it, that's okay. Pull hard. Now, every time I find a fixation, I always, in a thoracic, I always check to see if there's an anteriority underneath it. A lot of times the fixation is there to protect against the anteriority, so I'm just going to push P to A to challenge it. And it doesn't show that, but I just find it a lot, so I just routinely do that. Okay, sit up one more again.